we'll move right into our final session of the conference. And we just have our panelists coming in here. So as we get ready for the next session, we have to reflect on that many centers have developed strong genomic capabilities, but implementation remains quite variable across jurisdictions, as we were just chatting about in the previous session here. So this next session, from laboratory readiness to patient impact, will examine some of the most pressing constraints that are actually preventing CGP and related advanced testing from becoming routine practice. And we'll have a particular focus throughout this session on things like laboratory capacity, diagnostic workflows, and system readiness conditions. So please welcome Andrea Tjahja, who's the Vice President of Operations at the Medical Laboratory Professionals Association of Ontario, who will be moderating this discussion. Representing the patient perspective, we welcome both Dr. Christine Wong-Wu, a stage 4 lung cancer patient and a professor of engineering. And then we also welcome back Michelle Audoin, who's back with us again this afternoon after opening the day with us. She'll be sharing her perspectives as a stage 4 breast cancer and a thyroid cancer patient. Welcome to Craig Ivany, Adjunct Professor of Pathology and Lab Medicine at the University of British Columbia, Andrea Bahari, MLT and Manager of Clinical Services Advanced Diagnostics at William Osler Health System, Professor Brenda Gamble, Associate Professor and Program Director at Ontario Tech University. And joining us very shortly, I think he's just experiencing some technical difficulties, but we will have Dr. Jason Karamchandani back with us again. Dr. Karamchandani is the president of the Canadian Association of Pathologists and a valued member of CRAN's Medical Advisory Board as well. So welcome to all of our panelists. And Andrea, I will turn it over to you to get started, and Dr. Karamchandani will jump in as soon as he is able. And you're just on mute there, Andrea.
Thank you, Cassandra. I'm really pleased to be here and to help lead this discussion today. A very warm welcome to everyone who's joining us and to our expert panelists. As we've heard a lot about over the past two days, CGP is already playing an important role in metastatic cancer care. At the same time, newer tools like whole genome sequencing and other advanced molecular diagnostics are expanding what precision oncology can offer. But that progress also raises an important question. Are our systems ready to keep up? Even though we have strong evidence for the clinical and economic value of CGP, access and funding still vary widely across Canada. Many centers have built strong genomic expertise, but implementation remains inconsistent from one jurisdiction to another. So today, we want to talk about what is getting in the way of making CGP and other advanced genomic testing a routine part of care. That includes everything from lab capacity and diagnostic workflows to the broader readiness of the health system. So for our panel discussion today, we have 3 key objectives. The first is to identify the main barriers limiting consistent access to CGP and other advanced genomic testing across Canada. The second is to explore the system and workforce supports needed to expand genomic testing. And the third is to define the readiness conditions and enablers needed to make CGP a routine part of cancer care. So let's get started. To help ground today's discussion in real patient experience, we're very fortunate to hear from 2 patients whose journeys have been shaped by CGP. Their reflections will illustrate what patient impact looks like when testing and the diagnostic system works well, and when the testing and the systems break down. So I'd first like to invite Christine to share her experience of the positive impact of biomarker testing and how the right testing at the right time helped inform treatment decisions and contribute to positive outcomes.
Hi, thank you for having me here, and it's really an honor. And just want to let everybody know that I'm a 11 years survivor for advanced lung cancer, and my cancer has metastatic to my brain. And my 11-year survival is entirely because of the targeted therapy, which is dependent on the biomarker testing. Now, 11 years ago, biomarker testing was not available in Canada. And when my oncologist suggests biomarker testing, and I have to pay $5,000 US dollar out of my pocket to have the test done in the States. And I did that. And meanwhile, I have to wait for 1.5 months for the results. That's the way it is. And during that time, I started chemotherapy because I cannot wait. So after several months, my chemo stopped working. But fortunately, at this time, my test finally revealed that I had a ROS1 mutation. And this is, at the time, the clinical trial for ROS1 mutation in lung cancer just completed. The drug hasn't got the approval from from states yet. But anyway, my oncologist managed to get the compassionate use for the drug, and that's when I started targeted therapy, and the rest is history. And today, I'm still on the first line of the targeted therapy medicine, and this biomarker testing really saved my life. And but I want to say this clearly, that comprehensive genomic profile is absolutely vital. Yet we still face serious limitations, like we have already heard through this 2 days conference. But I just want to add my 2 points that, for example, in my province, I'm from Manitoba, and we have a newly established biomarker testing results 2 years ago. But it was only covered around 30 plus biomarkers for all types of cancers. And my ROS1 mutation won't even be detected through that panel today in Manitoba. So this is not acceptable, not because ROS1 mutation is not cannot be tested. Because, like, I'm a seasoned cancer patient. I know the doctors. I know the where I can get a comprehensive genomic profiling from states, from Toronto, But think about how about for those newly diagnosed patients? How about for those patients who just had an elapse? So without comprehensive genomic profiling, we risk missing the right treatment, missing access to clinical trial. We also may miss the opportunities to benefit from promising new therapy in development. And every patient deserves the full picture of the comprehensive genomic profiling, not a part of it. So when lives are at the stake, anything less than comprehensive genomic profile is simply not good enough. Thank you.
Thank you, Christine, for sharing that impactful story. I'd now like to invite Michelle to share her journey with pathology and diagnostic system failures, including the challenges accessing critical biomarker information.
Yeah, Christine, thanks for sharing your story. And for mine, it's not a story that of success. This is now 9 years of living with metastatic breast cancer, but it hasn't been an easy journey. And there's a couple of critical points, when you're diagnosed with metastatic breast cancer, where you need some of this biomarker testing. And that's like when you're diagnosed at the initial phase to determine, the profile of your cancer. And then when there's recurrence, and I've had, multiple recurrences of my disease. Unfortunately for me, when I was diagnosed, I had dense breasts and they could see one lump. And when they biopsied that one, it came back as stage 0 breast cancer. But the mammogram didn't pick up everything that was going on in my body. I had advocated for a bilateral mastectomy. Um, and that's where we saw that there were more things going on. Uh, and so my diagnosis was upgraded to a stage 2. Unfortunately, which is hard to believe, is that, I already lost my breast to breast cancer, but somewhere in the pathology realm, my actual breasts were lost. So all of that tissue, all of that sample got lost. And why that tissue was important was because, to determine whether chemo would be a useful option for me, they need that sample to run an oncotype score. And so we did not have my breast tissue anymore. All we had was a micrometastatic deposit that was too small, that was found in one of my sentinel lymph nodes. So I was really flying blind on my treatment. So we just decided, because I looked generally healthy, and I didn't have any other symptoms, that I was as sick as I was, that we would forego chemotherapy and just take a hormonal therapy, and for about 5 to 10 years. And I advocated again to just have a consult with a radiation oncologist, and that's when we discovered that I was actually metastatic all along. So both of my lungs had too many tumors to count. The disease had already progressed, and the biopsy of the lung had confirmed that yes, this was metastatic breast cancer. So that was my first disappointment with this whole pathology. It was because I didn't have all the right information at the right time, and I'm very grateful that I did advocate for to see the consults and to have all of those tests done. And since then, as I said, I've had progression a number of times in my lungs, where most of the tumors are stable, and then there's once in a while a tumor that just keeps growing while I'm on treatment. And there's options. Sometimes I've been suggested that I could do radiation therapy. I've always opted to have a biopsy. I'm sorry, actually a resection, so have that tumor removed, because I want the pathology part report. Because my initial breast tumor was gone, I feel that there's valuable information in that pathology report from those tumors that have been excised from my lungs. So that's where I'm at. It's just there's so much valuable information, but we do have to really make sure that the patient samples are cared for and that we know what we're doing with them.
Thank you, Michelle. That is an unfortunate story with your samples being lost, and you've been also on quite a journey. So I'd like to again say a huge thank you to Christine and Michelle for sharing their experiences with us. We've seen 2 examples, one of the system working well and one perhaps not so well. And as healthcare professionals, learning from these real patient experiences is so tremendously impactful and is really helping to set the stage for our panel discussion. So let's now move into our panel discussion. So our first question is for Dr. Karam Chandani and Craig Ivany. So the question is, we know there's growing evidence that CGP can improve care and bring value to the health system, but access is still inconsistent across Canada. So from your perspective, what are the biggest barriers to making CGP part of routine cancer care? And where do things most often break down in the testing process? And we'll start with Dr. Karam Chandani.
Andrea, thank you. And I'd like to thank Christine and Michelle, both of whom I thought your stories are formidable. Michelle, the idea of losing a specimen is exactly what keeps most pathologists up at night. So I'm terribly sorry to hear about that part of your healthcare experience. And I would describe, even though Christina, I think it's amazing that you were identified as having a ROS1 alteration back early in the days of ROS being understood as part of one of the causes of non-smoking associated lung cancer. But that's another example of a failure in that you were started on traditional chemotherapy before you got your CGP results. And fundamentally, I think many of the people on this panel and the people listening today understand the value of CGP. But if we don't give you those results, the results to the people taking care of you before you start your therapy, that is a systems failure. Now, Craig is a systems guy. I was lucky enough to see Craig in Vancouver 3 weeks ago, so I know he's going to share his insights with all of you here today. I'm going to speak as a laboratorian who, as the president of the Canadian Association of Pathologists, hear from my colleagues across the country. And the unfortunate reality is that we have uneven access to CGP testing. And as we had discussed earlier in the day, so people that have attended many sessions will have heard this before, but CGP means different things in different areas. So Christine pointed out very saliently that even in the current biomarker testing environment, that some of the panels in Manitoba may not capture a specific ROS1 alteration. So even access to genetic testing means different sites. Now, I will say this, the progress in the last 2 years is astonishing, mostly led by individual heroic efforts. So I think it's incredible that the leader of pathology in Prince Edward Island has forged relationships with the people at Dalhousie to have molecular testing offered where necessary or where they find any potential clinical upside, or even to Moncton for a slightly different panel. But there it is relying on personal relationships, individual heroic effort, and a positive healthcare system that understood the need to provide the patients of Prince Edward Island with access to that sort of testing. Now, again, I'm repeating things that many of people who have been listening all day have heard, but we have 10 healthcare systems, and we have different degrees of centralization. And so here in Quebec, we have an OptiLab system, and we do not bill any other hospitals in the province for services that we offer in the province of Quebec, meaning at least every patient who is treated here, in theory, has access to CGP testing. And we perform quite rigorous testing at my center. We do exomes, RNA-seq, two kinds of expanded cancer panels, and a brain tumor panel. So the only actual molecular tests we don't have in the province that I ever would want to access is methylation classification, and that really applies to brain tumors and sarcomas at this point. That being said, my hospital network takes care of people in Amos, Rouyn-Noranda, and Val-d'Or, nearly 1,000 kilometers to the north. The time delays involved in getting tissue from some of my partners, my colleagues in my own department, and providing them with timely results can exceed the duration of the need to start therapy within, sometimes in some cancers, 3 weeks or a month after the initial surgery. So we have made tremendous progress, but we're still not there, even in the provinces that I consider to be extremely well organized, on delivering the necessary results in a timely manner. And Christine's story is also amazing of how quickly these precision therapies can alter the outcome of incredibly aggressive tumors. And unfortunately, even the last 3 weeks in 3 different cities, I've heard of tragic stories where patients died from their disease, and only after they died did we uncover a targetable mutation. So while we've made progress, there's an incredible amount of work still to come. And that's why hearing these stories, sharing these stories with patients so they know to advocate for themselves in a complex healthcare system that is increasingly fragmented among many clinicians across several disciplines can be so incredibly important. So there's reason to have hope, but it's obviously still a challenging landscape. And the shortages in the workforce in the labs are no small obstacle. So we do not have enough lab technicians in this country, full stop. It is not a Canadian problem. It exists in the United Kingdom. It exists in the United States. So this is a global problem. So how do we interest people into going into this field to help us take care of these patients is a shared challenge for all of us. And that includes getting down to the level of interacting with high school students, to let them know about the possibility of an exciting career in this area. And finally, one last quick point to Michelle's story. Michelle's story is very interesting because after a tragic mishap in the lab where the specimen was lost, with these recurrences, there's an increasing question of how do you do the serial testing? So I'm a strong advocate for CGP at initial diagnosis as opposed to waiting for patients to become high stage. But for a patient like Michelle, when you have recurrences, when can we do serial testing? What should we do serial testing for? And how can we do that? And we are entering a new era with liquid biopsy. This is more advanced currently in lung tumors. So people have an EGFR mutation. We have some knowledge of some of the mutations that prevent the tumor from responding to first-line EGFR therapies. So liquid biopsies are going to play a role in the evolving world of lab medicine responding to patients with multiple recurrences. I believe that's going to be cancer specific, a combination of primary site and biology. But again, in addition to CGP, we have more work to do on the idea of continued surveillance and more investigation at the appropriate time during the recurrences. Thank you all for your time.
So, Andrea, I'll just pick up on some of the things that Jason mentioned, but I'll just start by I've been joining the conference over the last 2 days, Philomena, and I just want to first of all say I think it's a remarkable event. And I think we need to acknowledge Philomena, the CRAN team, and all of the contributors for this dialogue that we're having and advancing an agenda on access to important testing for cancer patients. And I think the voice of the patient, the voice of the human being going through this is so vital in trying to understand and solve some of these riddles. Before I get into kind of lab specifically, and I've listened to a number of discussions across the days, there's no question about it that we all recognize there are challenges within and across the health systems of our federation. Our health systems were born out of politics and democratic structures. The actual founding of our country, the BNA Act 1867, assigned the health as a provincial jurisdiction, as we understand. And subsequently in the 60s and 70s, through efforts of politicians, a social health insurance medicine model emerged. And so that's really structured how we as Canadians view our healthcare system. For a long time in the 60s and 70s, there's been primarily politics that shaped our health insurance systems, primarily by strong interests, some moneyed interests, frankly, and influences from professional groups, unions, influential vendors, and others with financial interests in controlling and influencing the health system's agendas. And as a result today, we have a rationed health system. In some ways, you spend in one area, you can't spend in another. We hear about all the silos and the spending challenges. And, and so from the perspective of where we've been, the politic created some of the great benefit we have today as Canadians with respect to our health system, but also some of the significant inertia that we experience in our health systems. So we spend a lot of money in our health systems in Canada, and yet the outcomes we expect are moderately successful at best. And I'm referring to the Commonwealth Fund's assessment of Canada's performance against other comparators globally. We get frustrated seeing this inertia, and I do believe it does have consequences on our healthcare system. What I've witnessed in my 40 years of work in healthcare is that there are two forces that have the capacity to change and transform healthcare. The first is regrettably through tragedy and crisis. And I'm thinking of the Creever inquiry or the Cameron inquiry that hit my home province, Newfoundland. They ultimately drive accountability and change after catastrophic failure. However, I think the most rewarding change processes that I've witnessed and have been part of and contributed to are those that are driven by citizen and patient advocates. I believe the process of change is this is the most positive sense of change that we can drive, and is truly based on our best democratic values. So what we're doing here today is vital to the future of our healthcare system. So just let me shift a little bit and I'll pick up on some of the things that Jason talked about with respect to lab medicine. So lab medicine occupies a unique and at times an underappreciated position in the healthcare system. It is a meso level, so a mid-level between policy and between the care that a patient gets with a practitioner. Meso level socio-medical technical system. It touches every aspect of our healthcare system. It actually has 8 or 9 different medical disciplines. And for example, medical biochemistry is as different from surgical pathology as orthopedics is to obstetrics. Yet, for many policy, funding, and administrative experts, it's viewed as a homogeneous whole, as opposed to the complexity that actually defines lab medicine. Further, by the virtue of its reach, there's a propensity by folks outside of the lab to think of lab medicine as a commodity or as a transactional event in somebody's health care. I think from my perspective, I believe that lab medicine is a fundamental critical infrastructure element to be treated as an investment in the transformation of the healthcare system, as opposed to being viewed as a transactional element of the health system. And why this is important is because more and more we as patients and citizens are expecting that the lab system functions as an integrated system across the entirety of a jurisdiction, whether that's Northern Quebec, Northern British Columbia, Labrador in Newfoundland, pick a location. We expect that it functions as an integrated whole, and that it operates at a minimum across that jurisdiction's space. But we certainly love to see, as we've heard from advocates today, it needs to operate across the entirety of Canada. And there's one other complexity that is not well known, is that lab medicine has the most complex informatics infrastructure within the entire healthcare system. You don't see that. This socio-medical technical system also relies on a lot of what we call pre-analytical and post-analytic functions. Michelle, unfortunately, just a horrible error that resulted in the loss of your precious specimens. And lab medicine actually, and diagnostics writ large, have a significant patient safety risk that is underestimated. And it's by virtue of all of these complexities associated with the delivery of getting that result to you and your practitioner that we have to deal with. The complexity of lab medicine is, and it's been written up in studies about patient errors and patient safety, that it essentially drives patient safety issues that we don't spend enough time understanding, probably because we think of lab in that commodity space. So depending on the jurisdiction you find yourself in Canada, it means that each lab system is structured differently, that the local contextual factors or institutional logics of funding, of regulation, of structure, of jurisdiction shape how that lab will function. And that could mean that it's a single structure serving the entire province, or it could mean multiple providers, hybrid, private, public, service delivery models. It could mean that there's separate legislation for lab medicine or not, that there could be clear compensation structures or not. And as Jason said, we've got a chronic health human resource challenge in this space. So for me, it's really about, as lab leaders in the system, as folks who get into the system piece, is to be pushing harder and harder on that notion of investing in system level coherence, within a jurisdiction and across jurisdictions. We heard about, the CDA should be pursuing things around testing just as much as it does with drugs. We've heard about standards across Canada from all of the different panels. Just remarkable insights. We heard of silos and the importance of turning those silos, horizontally. And those are the things that we have to get at. And they're very hard to get at because a lab test can be viewed as a transaction. It's got to come out of the drug budget or somebody's budget, and it's one more net add. I would advocate and stand on the ground that lab medicine is a fundamental investment in our health system. And if we get that right, we can actually do much, much more in terms of driving better health outcomes and meeting the needs of patients by being able to demonstrate solid investments in CGP, whole genome sequencing, and a whole array of other technologies that support us from screening all the way to monitoring in your care journey. So I'll just wrap up by saying CRAN is vital, it's critical. Indeed, what you do is essential to driving change and transformation. And someone who's lived in lab systems across Canada would encourage CRAN and others actually to consider thinking about how you can advocate for that criticality of pathology and lab medicine writ large, not solely on that CGP journey, because there's going to be new technologies coming down the road, and you want a strong lab system to support your care and the care of every member of your family, whether it's cancer, major depressive disorder, chronic disease, or any other issue. So that's a lot. It's my 2-minute elevator pitch, but I can't do it in 2 minutes because I'm born and raised in Newfoundland, and I can't say hello in less than 30 minutes. There you go. I'll leave you with that.
Thanks very much. As a lab professional, there was lots to unpack in that. So thank you very much. We're going to move on to our next question, which is for Brenda and Andrea. So as the need for CGP and other advanced genomic testing grows, what does the health system need to do most to support scalable implementation? So for example, what changes are needed in lab capacity, health human resources, and interprofessional collaboration so that testing can be done more efficiently and equitably? And we'll start with Brenda.
Thank you, Andrea, and thank you, Christine and Michelle, for sharing your stories. I really appreciate it. And I would like to thank Jason and Craig for setting the stage for me. I started off on the bench as an MLT and transitioned into academia and to policy and decision making. So I love both of your talks. I'm right on board with you, spot on. I want to focus on the health human resources. As Jason noted, there is a shortage worldwide. There's also here in Canada. And there are similar challenges related to increasing the supply and the working conditions of medical laboratory technologists in the diagnostic lab. Now, why am I focusing on medical laboratory technologists? Because genetic technologists were previously medical laboratory technologists to enter into the educational programs in Canada, which there are two, one in BC and one in Ontario. You need to be a certified general medical laboratory technologist or have an undergraduate Bachelor of Health Science degree. Plus the fact that genetic technologists must register with the MLT Regulatory College to legally practice in their province. So what is the path forward? Well, the training for medical genetic technologists is very narrow. It's selective. There are only 2 sites in Canada. It's done after they've already completed the general certificate for medical lab technology. And then they have to do a graduate diploma, and they also have to do clinical training. So it's an added on program, which probably is the right way to do it. But the fact that there's only 2 accredited training institutions in Canada, you wonder if we are going to have the capacity or the number of people we need to work in the labs as this area of science and medical treatment grows. The difficulty lies in quantifying this workforce for predictive planning. It's very difficult. There's currently no definite national registry data to indicate the exact number of genetic technologists working across Canada. The Canadian Institute for Health Information does collect data on health workforce trends, but unfortunately for the medical laboratory technology profession, they only collect aggregate data, data that you're not able to discern a number of things, including the specialty of the medical laboratory technologists. In Ontario, the College of Medical Laboratory Technologists of Ontario, which is the regulatory body for MLTs and genetic technologists, has published a report 2024 that indicated that of their membership, now you have to be a member of the college to practice Ontario. So they're capturing everyone who's working as an MLT or a genetic technologist in Ontario. Only 5% of the practicing MLTs report molecular genetics as their primary specialty. So this raises the question whether the current staffing levels can survive the exponential growth of advanced genetic testing. We don't know, right? So to expand the recruitment pipeline for both general MLTs and specialized genetic technologists, there is a need for provincial and federal governments to provide targeted grants directly to accredited institutions, ensuring financial support for students during their clinical placements. Additionally, increased funding should be directed towards educational programs to expand overall enrollment capacity. Crucial infrastructure priorities need to be included. Example, clinical simulation in the classroom. To get genetic technologists prepared to go out into the field, into their clinical placement during training, so they're ready to go, and that reduces the burden on the staff who is mentoring these people. And let's face it, our workforce is overworked and tired, and they need this extra support of the students coming to them in clinical placement in the lab with some training prior to that. I would also advocate for implementing a minimum data set that explicitly captures genetic technologists within the broader medical laboratory technology workforce. Planning is essential for first step towards achieving these goals. Why do I say that? We need the evidence to provide to the decision makers that yes, there truly is a shortage. We can count, we can tell you across Canada who works where, what they do, what their age are, when are they going to retire. And that just doesn't exist now. I'm working with a CIHR team. We've actually built that minimum data set. Medical lab technology are part of this, of our group of people who have been involved in this. In fact, the profession is part of the demonstration project that we have. So they're already on board for the implementation of a minimum data set. And as I said, if we're able to do that, we're working with CIHI, who used to collect record level data for MLTs, but they do no longer, only aggregate. We are working with CIHI, and we need to implement such a structure so we can count and we know who's working where and how many people we really need for the future. So our policymakers and decision makers will have the hard data that they need to prioritize the funding to this particular area. So that's my sell on this.
Thank you, Britta. Andrea?
Great. Thank you all for inviting me to this. It's a privilege to be on this panel. And I'm probably going to reiterate a lot of what has already been said. And I agree with almost all of it, or if not all of it. And I think as the demand for comprehensive genomic profiling and other advanced molecular tests continues to increase, we have to take a coordinated approach to ensure that testing can be implemented in a scalable, sustainable, and equitable manner. And I think the first thing on that list is lab capacity. Do labs have the resources to do this testing? How can we prepare, and what do we focus on? And I think labs need to invest in expanded testing through automation, standardized workflows, scalable technologies that can accommodate increasing specimen volumes without compromising quality or turnaround times. And we need to be strategic. We need to really be strategic in planning for equipment, reagent supply chains, bioinformatics resources, data storage. All of these things are really essential. Working with our vendors to negotiate pricing of reagents, because although most of these tests are funded in Ontario, some labs are running a deficit at the cost, as the cost of the reagents and the consumables are higher than the funding reimbursement. And one of the biggest points, I think, for lab readiness is standardized workflows. Things such as establishing clear criteria for specimen triage, prioritizing tissue stewardship, implementing reflex testing. I think really maximizing tissue utilization, including early review of specimens for tumor content, appropriate selection of blocks, optimized sectioning strategies of the tissue, and coordination of ancillary testing. And this topic of tissue issue, I believe, maybe that's what happened to Michelle's case, is always a concern, as most of these specimens are quite small and tissue is at a premium. And so teaching of our histology team up front and how to properly triage gross and cut tissue can lead to more tissue preservation for downstream testing. And this is crucial, as one of the indicators, at least from CCO, for ordering liquid biopsies is not enough tissue. And as great as liquid biopsies are, the assay itself is still not as sensitive as it is for solid tumor testing. So if labs can improve on their tissue management and streamline their workflow, we may be able to get results out as fast as we would a liquid biopsy. And here at my center, we integrated immunohistochemistry and molecular pathology into a single department. And I cross-trained our histology or our immunohistochemistry technologists in nucleic acid extraction and the operation of our automated sequencer. And by leveraging the existing histology workforce, one technologist can now cut and prepare tissue for both IHC and NGS testing and maximize tissue utilization and minimizing manual handoffs. And really embedding molecular testing directly into established pathology workflows can significantly improve turnaround times and reduce operational efficiencies. Not only does it improve turnaround time, but both the components, IHC and NGS, can be reported in a single report by the pathologist. And we don't have this fragmented reporting that can potentially lead to wrong treatment decisions by the oncologist. Example, if a PD-L1 report is sent out ahead of an NGS report and, lo and behold, you find an EGFR mutation, now what? They've already treated on that PD-L1 status. So I think just integrating this report into a single report can make a big difference as well. And by treating our NGS cases in an analogous fashion to IHC, our techs here were able to utilize their skill sets and make a seamless transition to incorporate NGS into their existing workflow. Most institutions don't have the budget to expand their workflows to hire dedicated molecular technologists. But using current histology staff, we can really develop our workforce training programs labs really should prioritize recruitment, succession planning, and cross-training of staff. And, you know, really expand their educational development opportunities to address current and future workforce shortages. I really believe that integrating immunohistochemistry molecular path theory into medical laboratory technologist programs is becoming increasingly important as biomarker-driven diagnostics expands. A key challenge for labs, as mentioned before, is that demand is growing faster than the availability of technologists. So education programs really need to prepare the existing workforce to participate and effectively, you know, really safely and effectively get into these workflows. I believe that a curriculum shift really needs to happen, and it could focus on building competencies and principles, workflow, and quality requirements of biomarker testing, rather than creating separate molecular specialists. Traditional histology education often emphasizes morphology and routine staining, but modern pathology requires understanding how morphology, immunohistochemistry, and molecular findings are all integrated. Technologists don't necessarily need to become molecular biologists, but they need enough theory to understand the workflow and to be able to troubleshoot. I think at this point, the histology technologist is no longer only producing slides. They're a critical part of the molecular diagnostic pathway. I really think too that labs can also participate in regional planning initiatives to ensure, you know, resources are aligned with projected demands and that access to advanced genomic testing can remain equitable regardless of patient location. Regional testing networks, centralized models may also help to optimize resource utilization and improve access for diverse geographic areas. But I think equally important is the integration of genomic results into the electronic health records to facilitate timely clinical decision-making and patient management so oncologists can get the access to their reports in a timely fashion. And lastly, I just want to say a strong partnership between the lab and medical oncology teams is one of the most important enablers of successful CGP implementation, and it's often overlooked when discussing capacity and infrastructure. Ongoing collaboration ensures that appropriate tests is selected and efficient use of limited resources, and it allows oncologists to understand the test capabilities, limitations, and turnaround times and specimen requirements, but it also gives the lab teams insight into evolving clinical needs and treatment decision-making. At Osler, where I work, we established a dedicated clinician to lab email box for test requests, inquiries, and real-time collaboration. This is not just for internal use, but available to clinicians across Ontario seeking, and broader, seeking biomarker testing. This one step eliminated the need to navigate multiple administrative layers, and incoming requests are now picked up and acted on within 5 minutes, improving responsiveness and workflow efficiency. So my last thought really is, as CGP expands, these collaborative relationships will be essential to deliver really efficient, high quality, and equitable precision oncology care. So thank you.
Thank you, Andrea. So for our last panel question, if Canada wants to make CGP a routine part of cancer care, what needs to be in place over the next 3 to 5 years to make that happen? And I'll just sort of open the floor to whoever would like to go first.
I'll be happy to go first, Andrea. Could you hear me, Andrea?
Yes, go ahead.
Okay, sorry. I'd like to respond to Andrea's presentation. I couldn't agree with you more. Collaboration is key, and that people, the lab professionals, the people working in the lab, need to be recognized as part of transdisciplinary teams. But the challenge that exists is that people do not appreciate the role of the lab, as Craig was saying. From my personal experience being part of Team Primary Care, which is a federally funded research unit, I was invited to be on that team because of my previous role as a medical laboratory technologist in my research. And the team co-lead who invited me has just told me, this has been 3 or 4 years ago we did this, that she had a hard time convincing the rest of the team, why do we need medical lab? You know, what do they do? And in fact, when I spoke to the person coordinating the writing of the grant, she said to me, well, don't lab people just take blood? It's hard to believe, but that thought is out there. So the key here is, yes, they need to be part of the transdisciplinary team, but how do we get people to recognize that and the value of the lab? I think that's very important. And with us not even counting medical lab technologists and what they do, they're invisible. And yet the provincial and federal governments of our country have consistently said, and I can document it back to 1988, that the lab is important. But where's the money to support that, to prioritize the funding and support education and the other things that are needed for the profession? So thank you.
Oh, Andrea, you're just muted there.
Sorry, I think we have time for one more comment. I see Dr. Karim Chandani is ready to go. Thanks.
So I'm going to talk about one aspect. We already talked about human resources being absolutely critical. But the reality is, and Craig talked about our fragmented healthcare system, Quebec is one of the few provinces, and we have duplicated the work of CDA with an organization called Readiness, which is very much in charge of approving drugs for the Quebec patient population. Now, in this province, at the very least, when a drug that has a companion diagnostic test, which would be an array of either immunohistochemical biomarkers, liquid biomarkers, or CGP, the companion diagnostic test is approved at the same time. That's actually not true in the rest of the country, where the CDA, after Health Canada approves a drug, makes a recommendation on the utility and cost benefit, and approves or suggests the approval of a drug. So as an example, in Ontario, Cancer Care Ontario is a formidable organization, and it has a wing that is entirely based in the lab. But the approval process for a companion diagnostic testing is not necessarily synchronous with an approval of a treatment pathway. So my colleagues in Ontario have to look through a crystal ball and predict the needs for certain advanced diagnostics 2 years in the future. I don't envy their task. I think they do a formidable job. But an adoption of a pan-Canadian system where there is a combination of an approval from CDA that inherently implies that whatever companion diagnostic testing that is required is also publicly funded, I think would go a long way into decreasing the adoption of these tests across the country. So there is immunotherapy has been absolutely transformative in lung cancer care. And there are examples of a drug being made available to a patient population, but the companion diagnostic test waited 18 months to be developed. Now, we have done a great disservice to our Canadian colleagues across the country when we suffer under the delays like that. And so, again, the remuneration for the companion testing in the lab with access to treatments going hand in hand, I think would be very helpful.
Excellent. Thank you. I'd just like to turn back to Michelle as we wrap things up. From your perspective as a patient, from your perspective, what would a system that's truly ready for precision oncology look like? And what changes are needed to ensure that patients can access the right testing at the right time?
That's a really great question. I think what patients need is a centralized, trustworthy, and, credible, reliable information about what CGP is, what tests are available, which ones are beneficial that's unique to their circumstances and their cancer. Christine went to the States and paid a lot of money out of pocket. And I know from women living with metastatic breast cancer, they hear about these liquid biopsies and these tests, and they're frustrated with their healthcare providers that they aren't ordering them, so they're paying out of pocket for tests that may not have any relevance to their cancer. So I think we really do need to empower the patients by having a centralized, trustworthy, reliable information, so that patients aren't paying out of pocket. And then that can also inform, some of their decision making with their oncologist, whether they want to be enrolled in a clinical trial or take the standard of care option that's available to them.
Thanks very much. We have just a couple minutes left for a couple of questions. So the first audience question we have is, the lab provides the results that support patient treatment in and out of the hospital. Do you feel that there is a path forward to having the laboratory as a revenue generator by studying the savings that the lab provides through results that allow proper treatment options, defining the true impact of the results that the laboratory provides?
I can jump in on that one a little bit. I wouldn't want to call it a revenue generator, but the business cases for lab testing from my perspective, are typically rock solid. I'll take something outside of the cancer realm. There are three genetic markers that indicate a person's capacity to metabolize drugs for major depressive disorder. If you test those patients for their metabolism genetics, the drug treatments would drive them to the appropriate drug treatment almost immediately or after one or two first applications of other drugs. If you use that testing, there's a 20-year estimated savings in the province of British Columbia of over $980 million. The province of British Columbia. Those are hard and soft savings, but it changes the dynamic of the lives of so many people who are on an odyssey in terms of trying to find the right drug treatment. And yet we don't have that as a course of treatment in the province or much of Canada, I would say. And so it is being able to bring solid business cases time and again that I think is so vital for lab services. The value of lab service is experienced outside of the lab. The value of lab services is delivered through oncologists. It's delivered through transplant specialists. It's delivered through general practitioners, and patients receive that benefit. And that's why I talk about lab as an investment vehicle. And perhaps you can articulate it in terms of the quantifiable savings, whether it's hard or soft dollars, but there is definitely an opportunity to express the value of lab medicine differently going forward.
I just want to add to that there was a study done a couple years ago. I believe Dr. Snow was on that paper, and you might not recognize the cost savings in the lab, but if you can get these test results out faster, it costs $400 a day, at least this is the study, a day to keep a patient in the hospital. And that's what it's costing the hospital. And so, if you can get those results out faster and get that patient home where they need to be, that is a cost savings. It might not come back directly to the lab, but there is a cost savings to the institution. So that should be recognized as well. The cost of the box of the sequencer is not as much as the workforce, the technologists that's where, you know, your resources are going to as well. So yeah, just to add that in.
Thanks, Andrea. So I think we're at time. I'd like to say thank you to our expert panelists for sharing your incredible insights and perspectives on CGP and the laboratory and the challenges that that we face, yet also providing some hope to what can come forward in the future and what needs to change or improve patient care. A special thank you also to Christine and Michelle for sharing your patient experiences. Hearing directly from patients really helped to ground this conversation, and you both had incredible, in different ways, experiences that really helped drive home what we were chatting about today in this discussion. So I also like to thank everyone who joined in today for the panel discussion and for contributing your questions. So thanks, everyone. And I'll turn it back to Cassandra.
Thank you so much, Andrea. There were some really, really great insights, but more importantly, opportunities identified through this panel discussion. So thank you on behalf of CRAN to the experts who participated in this session, and of course to Michelle and Christine for sharing your lived experiences with us today.